Dear friends and colleagues, today I'm going to discuss how should we manage a patient of tuberculosis as per the current guidelines and practice. You see, in the last few years, new diagnostics have come. There are new drugs in the market, and also accordingly, the new treatment regimes they have been proposed by various bodies. In routine, the WHO they issue the guidelines about the management, and they are discussed in India by the National Technical Expert Group. Some of them are accepted, some of them are not accepted because of several reasons. Now, unfortunately, the guidelines are changing very frequently, and it is difficult for any person, any physician or a chest physician to keep up with these guidelines. So today I'll try to make it simple that how should we manage tuberculosis as of 2026. So as I told you, you see, we are going to discuss how should we manage drug-sensitive and drug-resistant tuberculosis in 2026 and the future directions. If you have any questions with me, you can consult me on this email as well as on my mobile number. You see, if you look at the burden of tuberculosis in India compared to the global burden, we are contributing around 25% of the global incidence of TB cases, 28% of the global mortality from TB, and one-third of all the MDR-resistant incidents are contributed by India. Now let us discuss in brief all the laboratory aspects in tuberculosis. Now what we are following in the country is called Universal Drug Susceptibility Testing, that is UDST, that we are expected that in all TB patients, we should have an access to the DST for rifampicin, so we should know whether person is a rifampicin or not before we commence the treatment. And among the patients who are found to be rifampicin resistant, we should have DST for at least fluoroquinolones, so that when we begin with, we have DST for rifampicin as well as fluoroquinolones. And now there are genotypic tests for detection of drug reactions, which are quite rapid. Within say 1 or 2 days, they give you the answer. So like expert NTB, also called CBNet, Gene Expert, another is TrueNet. It tells us whether Mycobacterium tuberculosis is present or not, whether rifampicin resistance is there or not, and it detects TB even when your sputum AB smear is negative. Then with Gene Expert Ultra, called Expert MTB Ultra, it is much more sensitive than Gene Expert, and it detects bacilli even when they are fewer in number. But please remember the genotypic tests, they do not indicate the active disease as they are based on detection of genes of even the dead bacteria. When you look at the rapid test for detection of INH, because we need that, then we have first line LPA called line probe assay on the expert MTB XDR, which also tells us about the INH resistance. And then we have rapid test for detection of fluoroquinolones, that is the second line LPA and expert MTB XDR. So they are all again very useful to us. Now, how to proceed once you clinically suspect a tuberculosis in a patient as of now? So first step is you perform the sputum for AB smear, do the CBNet or TrueNet test, and do the X-ray of the chest. These are the basic minimum investigations. If MTB is not detected by these tests, then we evaluate the X-rays and the other tests. The few patients, remember, may need to be started on anti-TB medication based on the clinical X-ray and other features, but we should try all our attempts to have a microbiological evidence. And if you find MTB is detected, then we proceed. And this is the integrated diagnostic and treatment algorithm for drug susceptible and drug resistant TB as issued by the Ministry of Health, but I've tried to make it simple. So here in a suspected TB patient, you have performed the CBNet or TrueNet, and you find rifampicin resistance is not detected on the right side of the algorithm. So what we will do is we will immediately start the drug-sensitive TB treatment and send the first line LPA so that we know what about the INH resistance. And suppose LPA tells you that INH resistance is not detected, we will just continue the drug-sensitive TB treatment. Now, briefly looking what is the treatment of drug-sensitive TB today. So nothing has changed. It is 2 months of 4 drugs, rifampicin, INH, ethambutol, and pyrazinamide, followed by 4 months of rifampicin, INH, and ethambutol. In extrapulmonary tuberculosis, like CNS, skeletal, disseminated TB, we need to extend the treatment duration by 3 to 6 months. And now we are using fixed dose combinations called FDC, and one tablet has all the four drugs: INS 75 milligram, rifampicin 150 milligram, ethambutol 275 milligram, and pyrazinamide 400 milligram. Please remember now, in adults we have 5 weight bands, and we need to respect that. As you can see this table, you see depending on the weight band, one patient may need 2 tablets of this FDC or 4 or even 6. So this has to be followed. But if you look at the unfortunately the most common prescription in the market, I'm not naming the name of the brand. It has INS 300, rifampicin 450, ethambutol 800, and pyrazinamide 1500. So accordingly, many of the patients will be underdosed if you just follow the single prescription. So we need to respect the dosage. And now you see in the as per the ATS, CDC, ERS guidelines 2025, they have suggested 4 months of treatment regimes. One is the 4 months of rifampicin moxifloxacin based regime, and second is 4 months of regime based on SHINE trial, where we are giving the 2 months 4 drugs and followed by only 2 months of the 2 drugs. You see, these have been discussed in the National Technical Expert Group, and they have not accepted the recommendation for field implementation. There are several technical and logistic reasons I'm not going to detail, but as of now, these treatment regimes should not be used in India. Now coming to the same algorithm, suppose we send the first line LPA and you find INH resistance is detected. So what we will do is we will stop the drug sensitive TB treatment and start on a regime called H monopoly drug resistance regime. And what this regime is, it has 6 months of daily levofloxacin, rifampicin, ethambutol, and pyrazinamide. This is 6 months. And in certain situations, we need to extend the treatment to 9 months, like in patients with extensive disease, uncontrolled comorbidities, the extrapulmonary tuberculosis, if the smear is still positive at the end of 4 months, and if any replacement has been done in the regime. And in certain situations like CNS, skeletal, and biliary TB, the treatment may have to be given for 1 year. Let us see a case. So this 39-year-old male which complained of fever and cough for last 6 months, patient had taken the first line drugs for 2 months based on the sputum positive report, not improved, and at the end of the treatment, patient was again smeared 3+. The laboratory test showed, the CVNet showed there is no rifampicin resistance. First hand LP showed INH is resistance, no rifampicin is sensitive. Second hand LPA shows FQ and the SLI are sensitive, and major culture report is awaited. As you can see in the X-ray, it's a less severe disease. So we have a DSTB treated case for 2 months, not extensive tuberculosis, and at the end of intensive phase, patient is INS resistance with R sensitive. So he fulfills all the criteria for starting the treatment of H monopoly drug resistance. So 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide, they need to be given. Now let us see the management of MDR-XDR tuberculosis. You see, now we have 3 new drugs, and very important is to know the age criteria when they should be given, they should not be given. Bedaquiline, as of today in India, it can be given only to people 5 years and above and weighing at least 15 kg. For Delaminate has been approved for any age weighing 10 kg or more, and Predominate has been approved only for 14 years and above, and approved for use within the BPaLM regimen, not as a drug to be added to other regimens. So let us see what are the current Government of India guidelines and practices for the management of drug resistant tuberculosis. So let us go to the left side of the algorithm. So if you find that rifampicin resistance is detected, we will send further tests like first hand LPA to look for INH, second hand LPA to look for fluoroquinolones, injectables, expert XDR again to look for fluoroquinolones, citronamide, etc. And also the liquid culture measure, which is very important because we can use the results for extended DST again, all the 13 drugs. And then we look at the factors: age, fluoroquinolone resistance, extent of pulmonary TB, extrapulmonary TB, severe or not, mutation pattern, etc. I'll come to it later on. Based on these factors, we choose the regime. Broadly divided into 2. For patients who are 14 years or more, the first choice is BPaLM. Second choice, in case BPaLM cannot be given, is shorter oral 9 to 11 month regime. And the last choice is longer oral regime. In people who are less than 14 years of age, the BPaLM cannot be given because Predominate cannot be given. in people who are less than 14 years of age. The first choice is shorter oral regime, and the last choice is longer oral regime. You see, as you can see, the longer oral regime is like a grandfather, which embraces all type of patient when we cannot give the other regimes. So let us talk about the BPaLM regime. What was the evidence for BPaLM regime? You see, as you must have heard, initially there was a XDR-TB trial where the three drugs, bedaquiline, predominate, and linezolid was given for 6 months, extendable to 9 months among patients who were XDR-TB or who had failed to MDR-TB treatment. And you see, the results showed that this regime gave 90% success, which was very high. But here, the issue was the very high incidence of adverse drug reactions like neuropathy seen in 81% of cases and myelosuppression in 48% of cases. But here, one factor was that linezolid was used in the dosage of 1200 milligrams. So it was attributed to this high dose. So the next trial called Zenix trial was done, where there were 4 arms and different dosages and different duration of linezolid they were tried. And in the third arm, that is BPaL, with 26 weeks, with 6 milligrams linezolid for the entire duration. This gave the most acceptable results in the form of 91% efficacy, 24% peripheral neuropathy, and only 2% myelosuppression. Then we had this very important, it's a TB practical trial. It had more than 550 participants, and they were divided into the 4 arms. One was given only bedaquiline, predominant linezolid. Second arm had added moxifloxacin to BPaL. Third arm BPaL plus clofazimine, and fourth was the standard treatment arm of that particular country. So when they compared the results of the BPaLM versus BPaL arm, where the moxifloxacin was not given, the BPaLM gave culture conversion at 8 weeks, 77% compared to 45% in BPaL. And modified intensity to treat analysis, 72 weeks after randomization, the favorable outcomes were higher in the BPaLM, 88.7% compared to 76.7% in the BPaL arm. And even the recurrences at 72 weeks were none in BPaLM compared to 4 in BPaL arm. But we must know when to give and when not to give this regime. So the inclusion criteria for BPaLM where it can be given is person with MDR or resistance TB with or without active resistance, but age should be 14 years and above. Patient should not have received or have received less than 1 month of treatment with bedaquiline, predominant, or linezolid. Or if he exposed, then patient should be sensitive. Non-lactating women but not breastfeeding. Non-pregnant, but we can include pregnant female in case they are willing for MTP. Now, exclusion criteria where it should not be considered is people who have documented resistance to bedaquiline, linezolid, and or predominant. People with severe forms of extrapulmonary MDR-TB like CNS TB, spinal TB, skeletal TB, miliary TB, or disseminated TB, that is TB in more than 1 organs. Then people with significant liver dysfunctions, people with significant cardiac conduction abnormalities, and people who have QTCF more than 450 millisecond in males and more than 470 millisecond in females with normal electrolyte, there also should not be given. So we must remember that BPaLM can be given only if the age is 14 years and above, and is not to be given when there is severe extrapulmonary TB like CNS TB, spinal TB, skeletal TB, miliary TB, or disseminated TB. We need to remember this. Now coming to the regime dosages, remember it has to be given orally with food and adequate water. It is to be given for 26 weeks, roughly around 6 months, which may require extended to 39 weeks. I'll come to it later. And what are the drugs and dosages? Bedaquiline to be given in standard dosages, that is first 2 weeks, 400 milligram daily, and then third to 26 weeks, 200 milligram 3 times a week. Predominate 2 milligram OD once a day, linezolid 6 milligram once a day, moxifloxacin 400 milligram once a day. Same dose for all the weight bands. There is no weight band. No dose modification for any drug is accepted except for linezolid can be reduced to 300 milligram in case there is any intolerance. Regarding the duration and modifications, the treatment duration can be extended to 9 months, that is 39 weeks instead of 26 weeks, in case there has been a dose reduction of linezolid, which is required for the adverse drug reaction. But this reduction in dosage is permitted only after first 9 weeks of treatment. In case we have to stop moxifloxacin permanently, due to any ADR or any other reason, then also we have to extend the treatment to 39 weeks. Now, permanent stoppage of any other drug like moxifloxacin, other than moxifloxacin, the rest three drugs is not permitted. Here we have to declare the patient as failure to treatment. And also, please remember, in case of missed dosages of any of the core medicines, that is bedaquiline, predominant linezolid, we have to declare the treatment regime as failed if there are 2 consecutive weeks of interruption or cumulative weeks, that is 1 week now, then 1 week later on, 2 weeks later on. So cumulative 4 weeks is again to be declared as failed. Regarding the adverse reaction, please remember these four, that is peripheral neuropathy, myelosuppression, that is anemia, thrombocytopenia, QTC prolongation, optic neuritis. You see, these are the things which are most troublesome with this regime, and we need to be careful about this. If I share the initial experience at our institute where more than 220 patients have been enrolled, the peripheral neuropathy occurred in 12 patients. 7 patients required to stop the BPaLM, and 5 patients required dose reduction to 300 grams, but they could continue with the BPaLM to 39. Myelosuppression anemia occurred in 7 patients, but in most we could manage conservatively by giving blood transfusion, and the treatment regime was continued. QTC prolongation occurred in 1, and here the person could be managed conservatively, but ultimately lost to follow. And optic neuritis, none of the patient had optic neuritis. Let us see a case. So this is 29-year-old married female, 12 weeks pregnant, and she had fever off and on for last 8 months. You can see the X-ray, there is bilateral extensive disease, and she had received first-line drugs irregularly for 5 months and then lost to follow. The sputum examination showed the MTB present and rifampicin resistance, and first NLP showed INH high dose resistance also there, and second NLP showed levofloxacin mix of moxifloxacin high dose resistance, injectable sensitive. So this patient is 29-year-old female with 20 weeks pregnancy, MDR with INH high dose resistance also. So also resistant to levofloxacin and moxifloxacin high dose. She has extensive pulmonary TB but no severe extrapulmonary TB. So if you see, can we give BPaLM in this case? She fulfills all the criteria except that she is pregnant, so we cannot use BPaLM. So here we have to counsel the patient in case they agree for MTP. Then in that case, if like in this case she agreed, MTP was done, and we could start the BPaLM regime. However, suppose patient declines to go for the MTP, which can be there in the field conditions. And then in this scenario with rifampicin, F2 resistance, 12 weeks pregnancy, and PTB being extensive, can we give BPaLM? No, because she is pregnant. Can we give shorter role bedaquiline containing regimen? No, because there is fluoroquinolone resistance and extensive pulmonary TB. I will come to it later on when I talk about the shorter regime. Can we do longer role regimen? Yes. As I said, it embarrasses all kind of degradation cases. So it can be in this case to consider that. So, dear friends, if you see with the introduction of the BPaLM in a person with 55 kg, extreme left with the drugs, the DSTB treatment, just 4 drugs, longer role regime, you can't even count the number of tablets and capsules are there. And on the extreme right is BPaLM regime, where in the continuation phase we are using just 5 tablets, as good as drug sensitive TB. So it has significantly reduced the pill burden. And the first dose of BPaLM was given to a patient on 27th of December 24 at our institute in New Delhi. And you can see the dosage being given. And on the right side, the same patient is hale and hearty and completed successfully. And if you look at the current status of BPaLM in India as of March 26, more than 21,000 patients have been enrolled under BPaLM. All states and all union territories, they have initiated patient on BPaLM. There is no state or district in the country where this treatment is not available. Now coming to the shorter role bedaquiline containing regime, again very important is when to give, when not to give. So the inclusion criteria include that it should be rifampicin resistant without fluoroquinolone resistance, please remember. And it can be given to children 5 years and above because bedaquiline cannot be given to children who are less than 5 years. In PLHIV, it can be given. Looking at the exclusion criteria, it should not be given when we have extensive pulmonary TB or severe extrapulmonary TB, which includes miliary TB, CNS TB, meningitis, bone and joint TB, disseminated TB. Also, history of more than 1 month use of bedaquiline, linezolid, levofloxacin, ethionamide, or clofazimine, it should not be given unless the DST showed it is sensitive. If both ionized mutation and CAG mutations are present, here we can give linezolid containing regime, but not ethionamide containing regime. Similarly, in pregnancy, linezolid containing regime can be given, but ethionamide regime cannot be given or can be given only after 32 weeks of pregnancy when it is considered safe. So we must remember that the shorter oral bedaquiline containing regimen can be given in age 5 years and more, low fluoroquinolone resistance, no extensive pulmonary TB, no severe extrapulmonary TB. In these conditions, it can be given. Regime duration is 9 to 11 months. Intensive phase is 4 months. Extended to 6 months. It has 7 drugs, which includes bedaquiline for 6 months to 9 months, 2 months of linezolid. Then we have 5 other drugs: levofloxacin, Z, E, Clofa, and high-dose INH. And in the continuation phase, we give for 5 months 4 drugs: levofloxacin, Z, ethambutol, and clofazimine. The short-term beta, this MDR regime is a package of treatment, please remember, and no permanent stoppage or replacement of any drug is permitted. Then we have another regime which is called ethionamide containing regime, which is of 9 to 11 months. Intensive phase, again, and continuation phase are almost same, other than the fact that linezolid has been replaced by ethionamide, and this to be considered when linezolid cannot be given due to any adverse drug reactions. Now look at this X-ray. Can you give bedaquiline containing regimen? On the left X-ray, it is non-extensive, so we can give. On the right X-ray, it is extensive disease, so bedaquiline containing shorter regimen cannot be given. Let us see a case. So this 13-year-old female came with fever and cough for 9 months. She had taken twice the first time drugs for 4 months, lost to follow-up, 9 months, failed. And you can see the X-ray, it is less extensive disease. The sputum CVNet showed MTB present, rifampicin resistance. First LP showed INH high dose resistance, rifampicin resistance, and second line LPA fluoroquinolone sensitive, injectable sensitive. Fidget culture is awaited. So what regime to give? So we have a rifampicin resistance, 13-year, no acute resistance, non-extensive pulmonary TB. Can we give BPaLM? No, because patient is less than 14 years of age. Shorter regimen can we give? Yes. He has resistance with active resistance and non-extensive pulmonary TB. Sorry, resistance with no active resistance and non-extensive TB. Longer oral regime, it is not required. So in this case, we will be giving shorter oral bedaquiline containing regime. Now let us talk about the longer oral MDR-XDR-TB regime. So what is the evidence for this longer oral MDR-XDR-TB regime? You see, this was a study published in Lancet 2018. It was a landmark study because it changed the entire concept of treating MDR-XDR-TB patients. It was a study with individual patient data meta-analysis, 12,000 patients, 25 countries, 50 studies. So very high level of evidence. And it had 3 studies from India. One is from PGI Chandigarh, second from my institute, and third from the Mumbai group. What the study showed was here the role of individual drugs in the management of MDR-XDR-TB was evaluated, and it found that the oral drugs like fluoroquinolone, bedaquiline, linezolid are more effective than the injectable second-line drugs. Again, for the first time in the world, otherwise in MDR-TB, injections are the first line of treatment. It also showed that the kanamycin, caprimycin use may be associated with more adverse reactions, failure, relapses, and deaths, and also found that amikacin is associated with modest benefit. So again, it emphasized that oral drugs are superior to the injectable drugs. So based on this study, plus some other evidence, WHO regrouped their anti-TB drugs classification. Group A had drugs, levofloxacin, moxifloxacin, bedaquiline, linezolid, and they suggested to include all the 3 medicines. In Group B, we have clofazimine and cycloserine. One or both are to be added to make a regime. And then we have Group C. They are ready to complete the regime when we cannot make a regime out of Group A and Group B. And it has these drugs: ethambutol, delaminate, pyrazinamide, imipenem, filastatin, meropenem, amikacin, ethionamide, and PAS, etc. So what is the current longer regime in our country? That is 18 months extendable to 20 months. These 5 drugs, levofloxacin, bedaquiline to be given for 6 months or longer, linezolid, clofazimine and cycloserine. Linezolid initially we give for in the dose of 600 milligram, and after 6 months it is reduced to 300 milligram, and the intensive phase can vary from 6 months and extendable to 8 months. For XDR-TB patient, the duration of treatment is 20 months. Then there is replacement sequence in case out of the 5 drugs you cannot give 1 or 2 of them. Then the first choice to be given from the replacement sequence is delaminate. Next choice should be amikacin, only if sensitive, which we can know from second-hand LP results. Falcinamide, only if sensitive. Ethonamide, only if sensitive, which we can see by first-hand LPA. Then choice should be PAS, then ethambutol, then ringfence elastoquin. Let us see this case. So this 60-year-old male, known case of TBD on a regular treatment, was diagnosed as MDR-TB in June 24, and patient was given short oral bedaquiline containing regimen for 6 months. Up to December 24, and patient remains sputum positive. The X-ray test showed bilateral extensive disease. The sputum examination showed MTB present with rifampicin resistance. Sputum for first-hand LP showed INH high dose resistance with rifampicin resistance. Second-hand LP showed fluoroquinolone resistance while injections were sensitive. BJ culture report was awaited. So what we need to give in this scenario, 60-year-old male has received bedaquiline for more than 1 month, bilateral extensive pulmonary TB and also fluoroquinolone resistant, and H, R and fluoroquinolone are also resistant. So can we give BPaLM regime in this case? No, because patient has taken bedaquiline for more than 1 month. Can we give shorter oral regimen? No, several reasons. Patient has F2 resistance. Patient has bilateral extensive tuberculosis and has taken more than 1 month of bedaquiline. Can we give longer oral regime? Yes. In this case, we'll have to go to the longer oral regime. And what will be the regime is, again, same 5 drugs, but here being levofloxacin resistance, we have to replace levofloxacin by the first replacement drug, that is delaminate. And this treatment is to be reviewed once we have baseline DST report is available. So, dear friends, if you summarize the various treatment regime for various types of drug resistance TB today, that is 2026, we have, in case drug sensitive, then the drug sensitive TB treatment. In case there is H mono resistance, then we give H mono poly DR-TB regime, we have already discussed. And if there is a rifampicin resistance detected, then after doing the other microbiological tests, we look at these factors. Age will decide whether we can give BPaLM or not. Less than 14 years, we cannot give BPaLM. Less than 5 years, we cannot give bedaquiline. Fluoroquinolone resistance or not, this, if present, we cannot give shorter oral 9 to 11 months of regime. Then extent of the disease, if the pulmonary TB is extensive, 9 to 11 months of treatment cannot be given. And looking at the EPTB, if it is severe, then we cannot give the BPaLM regime. We cannot give to 9 to 11 months of shorter regimen. And also the mutation pattern in H and FQ, they also help us. So again, after doing all this, if you find the age is 14 years or more, the first choice will be BPaLM. If cannot be given, then it is a shorter oral 9-month regime. In case even that also cannot be given, that longer oral regime. And in case you find person is less than 14 years of age, then shorter oral 9-month regime is to be considered. If even that cannot be given, then longer oral regime is to be given. So looking at the innovations at our institute about the drug resistance TB, you see with the help of Echo Clinic, we are running this NITRD, CTD, NTF difficult to treat TB clinic, where the Central TB Division of the Ministry of Health and National Task Force of all the medical colleges, they have joined hands with us. And here what we do is, it's a hub and spoke model. At NITRD, we have the hub where we guide the rest of the spokes about the management protocol, etc. The stakeholders include our institute, the Central TB Division, the National Task Force, the district TB officers, state TB officers, medical officers, all of them are included in this. And here the case is presented, then we have case-based discussion, not only about the management, we also discuss about the how this case should be managed as per the latest guidelines, what are the new guidelines. If anything, the Central TB Division wants to disseminate to the listeners, that is also done here. So in this case, Any one of you want to join this clinic, you may send your name and email and the mobile number on this email. Please note down the simple NITRD ECHO, that is echo, at the rate gmail.com. You can send your details to this and you'll be getting information in future about this clinic. And also one more thing which I want to share with you is that in our institute, we have made this Manage TB India mobile application, which is to be used, which can be used for drug sensitive TB as well as drug resistance TB. And here you have to feed the basic data, the demographic data, the microbiological data, the X-ray and the laboratory data, the biochemistry data of the patient, including CBC, LFT, KFT, etc. And this will give you the diagnosis of the patient as well as treatment of the patient, including the drugs and the dosages. And this was developed by our institute and it has been endorsed by the Central TB Division of the Ministry of Health and Welfare for use across the country. So dear friends, what I would like to emphasize again is that we should use the genotypic method to know rifampicin and protocolon non-resistance before we commence any treatment. For MDR, PHR or XDR-TB patient, the first choice should be BPaLM. Second choice should be shorter oral 9 to 11 months of regime. And the last choice should be the longer oral regime. But we must check the appropriate situations before choosing the type of regime. BPaLM regime, shorter oral regime, or longer oral regime, as we've already discussed. And the preferred options are, of course, in the world are shorter and oral regimes to be used in MDR-TB patients. Thank you very much for a very patient listening. Thank you.